These are very exciting times in the treatment of advanced bladder cancer and even non-muscle invasive bladder cancer. We have a whole new therapeutic armamentarium that we're understanding how to use better in this disease, understanding the role of combinations of treatments of these treatments with standard therapies, whether or not they augment chemotherapy, whether they detract from chemotherapy even, which is also possible. In addition, the data we're learning from other tumor types is now being applied to bladder cancer in terms of other novel combinations. And I'm very excited about the new approaches with vaccine therapies, which are generally appear to be very well tolerated and would be useful in this patient population. In addition, IDO inhibitors also represent a very promising therapeutic approach, and large randomized phase 3 trials have launched testing several of these. One of the very interesting areas right now is whether or not the same people who benefit from chemotherapy also benefit the most from immunotherapy. Patients with high levels of mutations often have DNA damage repair genes that sensitize them to both chemotherapy and potentially immunotherapy. And there is the real possibility that in metastatic disease, the combinations with the right cytotoxic chemotherapy with immunotherapy might take a portion of patients who might do well with either group alone, either agent alone, and actually really synergize and lead to cures in patients who have DNA damage repair mutations. And so we think that there's a possibility that there are certain patient populations for whom this terminal illness might no longer be terminal if we apply the right treatments and understand the biology of the disease well enough. And so we and others are conducting clinical trials with these combinations and analyzing the tumor genome at the same time to better understand which are the groups of patients that will do extraordinarily well. At the same time, we need to remember that the majority of patients don't have these mutations, and we need to identify other approaches. And there are other approaches beyond immunotherapy that are promising at this time. There are classes of drugs called antibody-drug conjugates, which are also looking very promising with high response rates, selective delivery of chemotherapy to tumors based on a tumor antigen that drops the cytotoxic payload within the tumor. And there is some evidence that some of these cell kill mechanisms with those cytotoxics lead to immunogenic cell death and might actually themselves then synergize with checkpoint inhibitor therapy. And so beyond immunotherapy, there are multiple approaches that are being tested, many of which are looking very promising these days.